Welcome, everyone. I see some familiar faces and some people who are new to me, which is great. I hope Dr. Hoerger can find his way here.
Yeah, starting the spaces always takes a little while for everybody to find their way in.
Yeah. Well, the main person I'm concerned about finding his way in is Dr. Hoerger.
Yeah, you can send them a DM with the link maybe.
Now that's thinking. Yeah, because I don't know if the link on the top of my profile is going to work now that I shut the space down. The first one.
Yeah, I think it is invalid actually.
Okay, let me get him. Dum dum dum. Yeah, Dave, do you see him coming into the room, to the space? Hi, everyone. Welcome. We're just waiting for Dr. Herger. Oh, here he is. Did you bring him up, Dave?
I did.
Good job. Hey, Mike.
Hi, can you hear me?
Yep, can hear you perfectly. Can you hear me?
I can. Thanks for hosting.
Oh, thanks for coming. Uh, yeah, this is David, the co-host. I guess we'll wait a couple of seconds for the rest of the people to file in. I know your time is short. I had to close the original space, Mike, because it wasn't set to record, and I really want to have the space recorded so people can check in afterwards, re-listen to the parts that they missed, or invite friends to listen.
That sounds great. Thank you.
Yeah. How are you doing this afternoon? Busy, busy?
Oh, yeah, I've been in remote meetings all day. Happy to be
Yeah.
here, though.
Yeah, happy to have you. Okay, I guess we'll get started.
Can I ask a question? Is there a
Of
different link
course.
for this since you had to
Uh,
change?
yeah, I think it's a different link. I DM'd you the new link.
Oh, okay. Somebody just messaged me. Let's
Okay.
see.
If they're following you, they should see the space at the top of their phone
Hmm,
or on the side of their laptop, but it might not
that's
hurt
true.
to.
Well,
Yeah.
I'm not the savviest about finding spaces when they're running, so.
That is the nature of spaces.
Yes, you never know what's going to happen. But again, I thought it was worthwhile closing the old one down because it wasn't set to record,
Yeah.
and I thought it was important to record it. Um, well, how many people are there? Well, let's get started, and I guess that people will join us as we go along. They'll find us, and if not, they'll be able to listen to the recording. So actually, Mike, this is the first time you and I have actually talked in person.
That's true. Thank you.
Yeah. So I'd like to welcome everyone to the space this afternoon. Um, our guest is, as you know, is Dr. Mike Hoerger, PhD. Mike, it might take me all the rest of the afternoon to read your credentials, but PhD, MSCR, which I had to look up what that meant. It's Masters of Science in Clinical Research, and MBA. Um, so for those of you who don't know him, Dr. Hoerger is an international expert in psychosocial oncology as well as in pandemic mitigation. He's an associate professor of psychology, psychiatry, and oncology at Tulane University. He's the managing director of palliative care research at the University Medical Center of New Orleans and the co-director of the Population Health Sciences and Disparities Program at the Louisiana Cancer Research Center. But I think we would know him best. We'd know you best, I think, Mike, in your role as the director of the PMC, which is the Pandemic Mitigation Collaborative, which is the public U.S. COVID forecasting dashboard that models both current and future trends in COVID infections. Dr. Hoerger, did I leave anything out?
I think that's a great introduction. Thanks so much.
Okay. Before we move on, I'd like to introduce Dave, my co-host. Dave is a volunteer with an agency based in Vermont called All Brains Belong, an organization that focuses on promoting neuro-inclusion both in healthcare and the community. Dave himself has some chronic health issues as well as an intense interest in COVID mitigations, and more especially on the impact of COVID on the neurodivergent community. David is sometimes reads my mind, and he's really good at putting relevant materials in the nest, which is the area above the space, and also in the chat. So welcome, Dave. Thanks for your help today.
Glad to be of help.
Yeah. Anything you want to say before we begin, Dave?
No, I just want to welcome everyone. I hope everybody finds something useful today. And we're hoping that Lucy will want to continue doing these things. Thank you.
Thanks, Dave. Uh, yeah, actually, I think I probably will, but yeah, thank you, Dave. So we check in with Dr. Hoerger at a really significant time in that, according to his information and that of others, we're experiencing the second highest wave of SARS-CoV-2 infections in the history of the pandemic. We know also that children are just returning to school with the threat of infection imminent, as most classroom settings, as we know, don't adequately mitigate against SARS-2, leaving our children at serious risk. So welcome, Dr. Hoerger, and thank you for taking the time to be here and taking time out of your busy schedule to inform the community. So Dr. Hoerger, do you want me to call you Dr. Hoerger? Do you want Mike?
You can call me Mike, and I'm impressed that you pronounced Hoerger correctly.
Mike, I have to confess here. I wasn't sure. I was going to go with something like I knew it was something like Hoerger, but I listened to your video in which you described your method for forecasting, and happily you pronounce your own name in there. So that's how I knew I had gotten it right.
Well, feel free to call me Mike.
Okay, thanks, Mike. So, yeah, Mike, for those not familiar with your work, I'm wondering if you could just explain briefly the function of the Pandemic Mitigation Collaborative, how it began, and the means that you use to forecast current and future levels of infection.
Sure, I'd be happy to. So a bit on my background. I'm a clinical psychologist by training. I'm licensed in Louisiana and New York to provide therapy. what people might not realize is a clinical psychologist is trained to do clinical work, but is also trained to do statistics and clinical research methodology. So we have a pretty broad skill set. After my PhD, I did an MSCR, which is a clinical research degree at a school of medicine through an NIH-sponsored award. And that gave me more training in statistics and epidemiology. And then, things were going pretty smoothly in 2019. I'm sure a lot of you can relate to this. And, almost seemed too easy. And, I live in the deep South in the U.S., which has a ton of, problems to solve. And one of them is we need people with better management skills. And so I decided to start this 3-year part-time MBA program in fall of 2019. Really great timing. And eventually the pandemic took off. And so I'd started this degree program focused on developing my management skills. And it turns out that the finance people were the most cautious about COVID. And so I ended up taking a lot more finance classes than I intended. And a lot of the finance classes are very analytically focused. And we were doing all sorts of projects and homework and exams and papers that are very similar to what we do for the PMC forecast. Sometimes it was COVID data, sometimes it was other stuff, but very similar sort of modeling. And what I do is pretty basic in terms of what somebody who's even more advanced in financial analytics could pull off. But so early in the pandemic, I got news within the first couple weeks that I was getting a large research study funded by the American Cancer Society. It was focused on, and continues to be focused on, helping people with serious cancer diagnoses get access to the highest quality care. A lot of the work is in person and in close contact with people who are known to be very vulnerable. And in addition to that, at the time, I have a son who was at the time just under 2. And so, we were very concerned about COVID mitigation and how to, protect ourselves, protect vulnerable patients, all this stuff. So started studying a lot about the pandemic. We've done a number of different projects, not just the dashboard. You can go through the pmc19.com homepage and look at some of the work we've done. And we've posted some links to some of the other work that others have done as well. But the forecast, what got us interested in that? I was really interested in forecasting at the, leading into the Delta wave. Our oldest was about to go back to preschool, and it was clear here in the Deep South that COVID was picking up again after we were told that we had reached herd immunity or whatever. And started trying to do some forecasting from positivity ratios, and quickly realized that the situation was very bad and it was extremely difficult to forecast anything with positivity ratios. And so kind of put that on hold, ended up developing my analytic skills more, and started posting these models using wastewater data. So if you go to the dashboard, you can scroll down. There's a video that will tell you more than you ever want to know about how it works. But the basic idea is that wastewater correlates extremely highly with COVID transmission, and not just reported cases, but actual cases. If you use different metrics to estimate how much COVID is actually, how many real cases there are at any given time. And so there's kind of 2 pieces to it. One of it is case estimation, which I don't think is very interesting, but it is, just taking wastewater and mapping that onto how many infections per day. And then the more interesting component is the actual forecasting component, which is taking all of the data that we have and using that to predict what's going to happen over the next several weeks. And a simplified version of that is to think about 2 different components to modeling. So one is to take the stable history of the pandemic, what we know about how transmission varies over the course of the year. And there's variability to that, throughout the pandemic. But we know, for example, that transmission tends to peak around January 1 for these winter waves in the US. And so we have some interesting historical data where you can kind of map on, if you knew nothing about the current situation, what would we expect transmission to be like today, given what we know historically? And that's one component of it. The other component is it takes recent data from the past several weeks, and based on the trajectory of how wastewater levels are changing, predicts how things are likely to go over the next 4 weeks, adjusting that historical model based on the current moment of how high levels are and whether transmission seems to be accelerating or decelerating. So hopefully that's a nice intro to the model.
Yeah, thanks. And am I correct in that your forecast indicated that January 10th was going to be the peak of this wave?
Yes, you are. That's my expectation. And the range of that is probably for the U.S. is probably January 3rd to January 17th. It may be earlier in other countries. It may be earlier in the northeastern and midwestern part of the U.S. and a little bit later in the south and west. But also it varies a lot across communities, even within large regions or within state. So um, you know overall national U.S. average probably around January 10th. The specific date of the peak is sometimes somewhat arbitrary. So, for example, if on January 3rd, yesterday, the wastewater levels are 0.0001% higher than January 10th, it could be relatively arbitrary to say January 3rd is the peak versus the 10th. And we'll never really know for certain when the peak was on a specific date because it's all based on sampling. And if your sampling overrepresents the Northeast and underrepresents the South, then a true situation might represent a different peak. But somewhere between the 3rd and the 17th. And really what people should be thinking is that if you look at historical waves and surges, and if you look at the graphs I posted for the current situation, it's really high transmission for a long time. You can think of each wave or surge as lasting 2 to 3 months. And so yes, the peak month of it is very bad, but it's not like there's just 3 days where transmission is awful and then you can go back to less mitigation.
Yeah, go ahead, Dave.
Is your modeling based on the United States, or is this a global data set?
This is based on United States data from wastewater supplied by BioBot, which is a wastewater company that has had partnerships with all sorts of different organizations, but predominantly the CDC. And they recently lost their contract with the CDC, Centers for Disease Control, which I believe they're disputing in court. But beyond that, they have a number, I think about 100 or so wastewater sites that they continue to have contracts with regardless.
Okay, and yeah, Mike, my understanding is that before they ended the testing programs, you were also using the results of PCR tests, was it? And you found a very high correlation between the results of those tests and the wastewater samples. And so that's how you are continuing to use the wastewater and consider it to be accurate.
Sort of. So I was using, what you want to use is some, ideal indicator of what you think reflects actual transmission. And in the US, we have this program called IHME, Institute for Health Metrics and Evaluation. And they were doing really great modeling for a long time. And they ended on April 1st. And you can go, their website is healthdata.org, but if you just Google IHME, you'll find their website, or you could Google IHME cases or forecasts or something like that. And you'll find what they were doing up until April 1st. And so they had really good estimates based on, a multi-dimensional model that you can read about to identify what they believed the true level of transmission was up until that time point. And so taking the wastewater data and correlating with that, you just see an extremely high correlation. And I talk a lot to other modelers who are not doing anything publicly and have done similar sorts of analyses, and they agree it's very high correspondence. What I post in terms of translating wastewater levels into cases is very simplified. there's much more advanced models you could do. Like, for example, one of the nuances is that as you're going into a wave or a surge, wastewater may underestimate transmission a little bit, and on the back end of a wave or a surge, it may overestimate transmission a little bit. But on average, over the course of weeks or months, those are pretty minor differences. But so anyway, it was using them, the IHME data, as a valid outcome to compare to. You can compare wastewater levels to other metrics as well. So you can compare two wastewater data sets with each other. You can compare wastewater levels to like the Walgreens positivity ratio or number of cases or number of tests being done. And that works pretty well over the short term. If you use like 3 months or 6 months of data. The problem with the Walgreens dashboard is that by and large testing has dropped off considerably the past year, but the peak of their testing was, I think, something like September or October of 2021. So testing has just gone way down if you're using that. But there's all sorts of different metrics you can use, and the basic idea is that wastewater just correlates very well in ways you'd expect with these different metrics. And in psychology, we call that validity or measurement validity.
So, Mike, I think the question on people's minds, or one question is, when do you expect this wave to be over? I know personally many people in the community are have changed, for example, medical appointments based on the thought that there's so much transmissibility right now that it might be better to wait a month, 3 weeks. So can you speak to that a bit?
Yeah, sure. So first of all, I'm not giving any individually tailored medical advice, so nobody can sue me. What I think about is, first you got to make these decisions with your medical team. So I'm not in charge of your medical decisions. But I think of basically two different types of medical decisions. One is where something is urgent and needs to be done, and that takes a higher level of priority. The other is if you've got something that really can be scheduled at any time. When might you choose to do that? Like a non-urgent dental appointment, for example. When would you do that? And I've said for a very long time, if anyone tries to tell you the state of the pandemic 2 months from now, you probably should not listen to them, because there's so much that could change. There could be some kind of new variant, or maybe we'll get lucky at some point. There will be some kind of breakthrough vaccine or treatment that could be really a game changer. And that's something that a model like mine just can't predict. But what I do tell people about is look at the historical trends. And I've posted a figure that outlines historically what the levels of transmission are. And there's variability from year to year. But one thing that's been relatively consistent is in the US, transmission goes way down from the start of February to the end of February. So if you take that as something that's likely to continue in the future, then a good time to schedule a non-urgent appointment might be late February or something like that. Now that can change. It could be that this current surge carries on 2 weeks longer than typical, or it could be there's some new variant or something that changes that trajectory. So it's nothing that's set in stone, but if I were in that situation, that's what I would be thinking about.
Yeah, thank you for making the distinction between urgent and non-urgent appointments. David, did you have something you wanted to ask?
There's a guest question. It says, can you ask if the wastewater is serology analyzed for variants, and if so, are the waves associated with the majority variant, e.g. JN1?
Yeah, so my role in this is basically to take the wastewater levels that BioBot is posting. I think what people should realize that isn't really discussed very much is that there's a lot of specialized scientific expertise that goes from dealing with the actual wastewater and getting that into a useful metric. And so sometimes I'll hear people say things like, well, are these levels valid because what if there's a new variant, or what if communities differ in their demographics, or what if there's different patterns of weather that affect the amount of rainwater in the wastewater and all these sorts of things. What I would say is, this is a scientific discipline with expertise on that. So the sort of questions that people ask me, or that I would even have, to me, that's at such a basic level that they're mostly accounting for that. It is an area of immense skill. And so that's why when I run analyses with like the BioBot data versus the Verily wastewater data, I get a closer correspondence with IHME case rate transmission using the BioBot data. And I think it's something about that scientific process that they've got more expertise in converting raw wastewater into a useful metric. And so they're analyzing things like what type of variants are appearing and how to handle all that. My model does not do anything that is variant specific. It doesn't do anything weather specific or related to how many people are traveling by plane or anything like that. That's all sort of baked into the model. The weather issues and travel and all that, to the extent that that has any sort of consistent pattern year over year, is already built into the model. And then the model updates those historical trends based on what's happening the past several weeks. So it would not be a good model for detecting some immune evasive variant 6 weeks out, but 2 weeks out, 3 weeks out, it's going to be a pretty good model. There's nothing I could throw into the model as hypothetical data that would give me anything that would look like the BA1 surge at a national level. But it does seem pretty clear that we're likely in the second largest surge.
Okay, that's really helpful because there was some discussion about this particular variant causing an increase in the wastewater level because it was more intestinally focused. But you're saying that BioBot would take that into account?
Yeah, I mean, it's like, if all of us brainstormed 100 concerns about those types of issues, to me, it would be so, like the scientists who are actually dealing with that issue, they would probably laugh because it's, they're dealing with that and a lot more sophisticated issues. The challenge is, and they do post some of that information on their website. It's a little bit hard to search for, but they have some blog posts about how they deal with these sorts of nuanced issues. But the challenge is they're using proprietary data. They're a private company and they have competitors. So they can't tell us everything about the nuances of what they're doing, or that would reduce their competitive advantage. And other companies could, invade into their market, as we've seen has happened with Verily getting the CDC contract. So they have to be, somewhat private about how they're doing these things. That's one of the issues with a public entity like the CDC and others outsourcing their work to private entities, is then there's less transparency. And so people have questions and may discount a certain type of data because of that lack of transparency. It was really easy for people to understand positivity ratios, but now that we don't do much testing in most places in the US, it's not really relevant. So people kind of have this idea in their mind of what's simple and easy to understand and make sense in terms of tracking transmission, and that's kind of no longer useful. And then this wastewater thing seems pretty strange to a lot of people and unfamiliar. And I think people by default aren't, really ready to trust that sometimes.
Yeah, thanks. But the information you're providing today is reassuring as to the accuracy of that information. And maybe David can find the BioBot website with their information at some point.
Can I add one other point?
Yeah. Oh,
So
yeah.
for people, probably not the people here, but for those of you who are talking to family members or friends and trying to convince them of something, a really easy thing to do is you can take like the case estimates that I've made, and you can compare them to what BNO is reporting on a weekly basis. BNO is compiling state level data in the US on number of reported cases. And if you look over the past 2 years, give or take, I think this would apply even going into the BA1 wave, estimates of actual cases are typically about 25 times the estimates of reported cases. And this varies a little bit depending on what the state of transmission is. So if you're in a lull, I don't really like that term, but between peaks, it's more like about 15x. And then if you're at like going into a peak, it may be about 30x. And these numbers may increase a little bit over time as less and less people are doing reportable testing. But that number is relatively stable, within this range that I'm describing. It's not like these wastewater derived case estimates are now 100 times the self-reported cases, or 1,000 or 10,000 times. So it's not like there's just some bias that has suddenly swept in with some new variant, and now we're seeing some ridiculous explosion where the wastewater estimates no longer correspond to self-reported cases in ways that are different from history.
That's really helpful to know. Yeah, because there was some concern again about this variant affecting the wastewater levels. Um, yeah, Mike, I also know that you have another project on the go called the COVID Canada. Oh, sorry, COVICon project. Um, so I guess that's COVID Cancer Project. Can you tell us a little bit about that and maybe what has been the response from the healthcare and from public health on that,
Sure.
on your project, the results of that?
Yeah, and I mentioned in a tweet that I would have 3 announcements today. I've got 1 real announcement and 2, I guess, are kind of half announcements. I'll start with the half announcements. So with the PMC dashboard and the Twitter threads that we put out, we've noted that we were going to make some awards based on who is doing the most and the most interesting work to use this sort of data to try and help other people. And we are going to announce those award winners tomorrow. So check on Twitter tomorrow to see some of the great work that people have been doing. The other thing is, the other half announcement is we'll have a paper out probably in about an hour and a half that will be citing the PMC dashboard as a reference, not as the main empirical focus, in a very reputable journal. And I'll start to build up a list more of where the most reputable sources are that are using the dashboard, because sometimes that's helpful if you're talking to people who need some convincing and defer to authority and that sort of thing. And then the third announcement is related to this COVICan project. So this COVICan project is basically designed to remedy some of the gaps in terms of what healthcare should be doing. So we published a paper in JAMA Oncology. I think the print version of it came out just under a year ago, maybe in March. It was accepted just over a year ago. And we outlined our top 10 tips for what health systems, especially cancer centers, should be doing to support patients and families through the pandemic. We know that people with cancer are among the most obviously empirically identifiable group of people who are at risk for severe outcomes of COVID. And obviously there are other subgroups that are identifiable as being very high risk. And there are many people who are high risk and don't know it. And likely everyone or just about everyone is at risk of long COVID through repeat infection. So I don't mean to minimize the impact for everybody, but cancer is a particularly risky group. And so we published this paper showing what cancer centers should be doing to support patients. And obviously most of them are not. Most medical centers are not doing a tenth of what they should be doing to support patients in avoiding getting COVID infections. and counseling them in general about the seriousness of the pandemic and the importance of avoiding reinfections. So we have this project. It's started off as a local pilot. We're in the process of doing a very small expansion to others in the US as a pilot. And the project focuses on really four main things. We give people a booklet that basically explains what most of us know, most of us who are in this chat know about COVID and how it transmits and how you avoid getting it and all of that stuff. It provides people with 2 DIY air cleaners that they can use in their home, since a lot of transmission occurs in home, and provides them with masks, mostly N95s, but the masks are not just for adult patients, they can be for patient's family. And obviously many people have children, and children, you know, if they're younger especially, are not going to be able to wear an N95 in any way that fits particularly well. So you have some KN95s and other sorts of options too. And the goal with that is to get people, wearing masks, if they're wearing masks, that fit them well and that they like wearing and that are comfortable for them. And then the fourth component is just rapid testing. And so it's kind of this COVID defense toolkit for people who have cancer. And our other major announcement is we're going to apply for a grant that's due in May. That will be a very large national expansion of this program. I will post more on this on Twitter in probably the next week, because we're going to be looking for collaborative involvement with this, with other clinicians, scientists, patients and families, anyone with technical expertise related to COVID. The requirements are generally that the people are in the US, but there are some exceptions to that. But I'll post more detail on this in the future. I think if it gets funded, it's going to be one of the most important studies evaluating community use of PPE, of these sorts of interventions, and demonstrating their impact and their benefit. And will really put to rest a lot of the nonsense that people read, about, oh, masks don't work or air cleaning doesn't work or all that sort of stuff. So more on that to come, but the pilot project is underway.
Great. Yeah, I know that article on JAMA was the most disseminated article on social media. So congratulations on that.
Oh, thanks. Yeah, it was one of their top ones. I mean, it's not like a breakthrough drug. So there were, other articles that have been transmitted more. But it was quite remarkable in that, JAMA Oncology is one of the top cancer journals in the world. And so it's actually rare for a psychologist to publish in a journal like that, and even rarer for it to be on something like masking and COVID mitigation and all that sort of stuff. And so I hope that gives people some sense of validation that these are important issues, and that a lot of people care about safety in medical centers, and that medical centers should be supporting pandemic safety and should not seem like and often be a place that is very risky for patients.
Have you found much cooperation in your local healthcare facilities with the steps that you're recommending? Because a common concern in the community is, as you said, fear about accessing medical care, because healthcare workers are generally not masking, or if they are masking, they're wearing baggy blues, that kind of thing. Is that your experience as well? And do you have any tips for us in trying to encourage our healthcare providers to take adequate mitigation steps?
My local situation, I don't think, is really much different than anywhere else in the US. And so you may see more and more stories. Well, you've certainly seen them the past couple weeks, and we'll see more the next couple weeks, of hospitals requiring masking again, with varying exceptions to the rule that are sometimes often very problematic. But at least some places are doing that. New Orleans is very strange because I would say through maybe the month or two after the BA1 Omicron surge, we were like, near the top for COVID mitigation in terms of policy and behavior, really ahead of a lot of places. And after BA1, that really changed. And now, the level of COVID mitigation around here is extremely low. And I'm sure a lot of people identify with that of like, the same people who used to mock people for not masking or getting vaccines are now the same people that are doing that, not masking and not getting up to date on their vaccines and all that sort of thing. So local picture here, very similar to other places. The study I described that we'll submit a grant for, is something that can address that longer term. But and that's how you affect policy, is you have very important research studies that change clinical practice, but that's all very slow. And so the way I approach things is that, is the perspective of over the shorter term, trying to empower people with information and tools that can be useful as they're dealing with these sorts of injustice and ableism and discrimination that are making it very challenging to get medical care and engage in very basic societal functions. So I wish I had better news locally, but I see the same struggles as most people.
Okay. Also, I guess kind of related to your locality, we know that there's a very large BIPOC community in your area that was very much affected by Hurricane Katrina, and I'm wondering whether there has been any particular outreach to the BIPOC community that you're aware of, and what the results of that have been.
Yeah, I would say, the issues you're describing are in part why my research team began taking COVID so seriously at a pretty early point. There are a lot of reasons, but part of it is just that in this part of the US, the deep South, Louisiana, Mississippi, Alabama, we're basically always competing to be dead last or near dead last on just about any health outcome. And if you look at the vaccination rates, as one, relatively easily tracked indicator, very, very low in this part of the country relative to other parts. Same thing for boosters, same thing for child vaccinations. Even, the number of people who have had any COVID vaccination at all is extremely low. And at one point, I don't know if this is still true, one of our parishes in Louisiana, counties are called parishes. One of the parishes was like almost dead last in the US, and I think had like 8% vaccination rates, and with any COVID vaccination. And maybe that's crept up to 15% or something by now, but just so much lower than if you look at like Boston or New York City or San Francisco or anything like that. And so it's absolutely a health disparities issue in terms of vaccination levels, the low attention to indoor air quality. I think is going to cause a lot more reinfections, especially in children in this part of the country, which may be surprising to people. You would think this part of the country has pretty good weather most of the year, so maybe we could have windows and doors open more. Most of the schools around here don't have windows that can open, do not have HVAC systems. The ones I've tested have absolutely terrible air quality. And so, these are some of the important issues. Another important issue is we have a very large service industry particularly related to tourism. And that's obviously a very risky setting to work. At the very start of the pandemic, we had absolutely horrific transmission, and our per capita case rates and mortality rates were very similar to New York City, and on some metrics worse, which a lot of people don't realize since we're the 50th largest city in the US. We're not New York City, but just absolutely very bad here from the start, and especially since BA1. And so one of our projects that was about a year and a half was focused on the service industry, and trying to understand the needs of people in service industry. And then we've done, my lab has done a lot of work on health disparities in COVID mortality. And some of those papers are, 99% along, but aren't out yet. But the disparities are exactly what you would expect, that people of color, people who have less education, people with lower income, worse COVID outcomes. And that's been replicated in many even higher quality publications that are already out.
Thank you. Yeah, that gives a lot of food for thought. Although there are some studies that have come out that say that people of color are more likely to mask than white people. Have you seen studies like that, or am I imagining this?
I wouldn't deny that such a study exists. I have not personally seen or read that study. That is my local observation, which may or may not be accurate, but that certainly seems to be the case. It's very frustrating, for many of us that work at universities, where you have people who have a lot of education, higher income, especially at private universities like where I am, where students come from very wealthy families often. Student population at my university, and at many disproportionately white. And with all the resources and knowledge that a university has, we could really be leading on COVID mitigation. Not just my university, universities as a group could have come together and really taken the lead on addressing these important issues. And instead, it's more like niche scientists, a few people at this university, a few people at that university, as opposed to it being the dominant focus or narrative at a university, which is what I think it should be.
Yeah, thank you. So the distress that I described earlier was around people being concerned about being able to access medical care safely. Another common source of distress in the community is that the idea about what constitutes adequate precautions against COVID, particularly masking, often differs between family members. Those of us who feel that masking is vital are often gaslighted, made to feel crazy and extreme. You know the deal, are told that we're too frightened, that COVID is not as serious as we think, and that we should be living basically the way we were in 2019 before COVID came on the scene. Do you, as a person who studied psychology, do you have any ideas about how we can approach these attitudes and change some of these attitudes in the people that we care about?
Yeah, that's a very common question I get. I think a lot of people are in very frustrating, impossible sorts of situations where these different views exist within the home or within a family unit where people co-reside to some extent. Like, I think one of the most difficult scenarios would be if a couple has gotten divorced and has children, and one parent is very supportive of COVID mitigation and the other is not and is doing the opposite, of how challenging that is. Another, just thinking through some of the scenarios. So like another situation is if someone has a vulnerable family member, an older family member who is getting lots of medical care, requires in-home medical care, anything like this, that adds a lot of risk. Even if everyone's on the same page, it's adding a lot of risk. But especially if you have somebody in the family unit who's not taking things very seriously. And then, other situations are like at school. Most schools have poor mitigation. You may have somebody in a workplace setting that's very dangerous. So there's a lot of different environmental risk profiles, and then you have different family members who have different views about this too. If we're talking about somebody who does not live in your home, then I think people should be protective of themselves and their own value and esteem. And you don't need to put up with this stuff just because it's family. You can set boundaries, and I think that's an important thing to do. You can set rules if it's about somebody visiting their niece or nephew or grandchild or that sort of thing, if it's not a legal situation where there's joint custody or something like that. So boundary setting is important. I would really encourage people to give more thought to that. When people are hearing these things of like masking doesn't work or it's the flu or something, I would take that as, people living in fear. And a lot of times that's said in the opposite direction. Like, why are you wearing a mask? You're living in fear. You're scared of COVID. And it's not really true. I would say the people who do not take the pandemic seriously, who are more likely to be living in fear, or they could be benefiting from some financial arrangement through these views. But a lot of times there's fear baked into that, and not 100% that's the only driving factor. But for someone to believe that COVID is like the flu, that requires a level of distortion that I would say must be driven in part by some emotional component that is fear-based surrounding our existence as humans that are mortal. And so that's a lot of what people are dealing with. And if you just try to approach it as like, I'm going to print off some articles or I'm going to show you this graph and that's going to change things, you're skipping over that emotional element, and it may not be successful. And so there may be some ways to try to build some empathy with family members who are struggling with these sorts of fear-based issues, in addition to setting boundaries. The other approach I would take is to really consider the long view. And so as a therapist, anyone who's ever been a therapist or had a similar sort of occupation, there's this very common situation where you'll be working with a client or patient or whatever your people are called or prefer to be called, and in this therapeutic setting, and you're giving some sort of advice or suggestion or trying to help them move in a particular way that's hopefully helpful. And you might say the same thing like 20 times over the course of 6 months, and the person's no, and just ignores what you say. And then eventually enough time goes by and they do or they say the exact same thing you've been suggesting, and sometimes with no obvious awareness that you've ever even mentioned this. And that's a win therapeutically. You don't need to get credit for somebody acknowledging that this idea came from you. But that's a very common situation, and it takes a long time. And so people imagine that I show somebody a graph and then they start wearing a mask. And that's just not how things work. It's very slow for people to change their behavior. And so if you are providing helpful information to people and they're not listening, I would say know that maybe in 6 months they'll change something, and they may or may not even credit that to you. They may change something after their next infection. They may change something after they're experiencing some symptoms of long COVID, or after a friend or family member is dealing with some of these issues. So it can be very long term. And you can still set boundaries. You don't have to go out of your way to be helpful to somebody who has ignored you for a long time and then wants your support. But know that these are long-term emotional issues, and it's very difficult to change behavior. Anyone who's trying to do this, you're doing health psychology, which is what I do. I lead our health psychology PhD program. This is something you can train in for years, and so you're trying to do this and you're seeing exactly how hard it is, and it is hard.
Yeah, so you're saying to set realistic boundaries for safety for yourself and your family. What intrigues me is that you also mentioned showing empathy for those family members who are saying that they don't agree with masking. Could you explain that a bit more?
Yes, and I say set boundaries first. You don't have to ever put yourself in a situation that devalues yourself, um, and so that's very important. But if it's somebody who maybe you feel is on the fence, or somebody that you want to help, that you're not just going to set boundaries with, or that you haven't set that sort of boundary with yet. Um, I think having some empathy for the fact that they are dealing with a lot of fear, and that they may not even be aware of the extent that their fear about mortality is affecting them so much, that is something that is true and that exists, and they're scared of something, and so scared that they're not even perhaps able to vocalize that, or to take behaviors or precautions that could be protecting themselves better. And as a society, that's a very big problem. It's unfortunate how much of that is falling onto individuals, um, uh, but that's the place we're at. So I would try to have empathy, but set boundaries, take care of yourself. Don't allow yourself to be devalued.
And I think you're also saying that repetition may help as well. Repetition of uh, factual information, and that at some point they may end up coming back to you with the same facts that you've been telling them, and to just not feel the need to take credit for that, but to um, maybe give them credit for having come to this realization.
Yeah, I think that's an important point. You don't ever want to feel like you're nagging somebody, or this is becoming a tedious job, or any of that sort of stuff, but that you can be willing to try to take these steps multiple times over time. Um, and I think your questions are kind of getting more at these more conflictual oriented scenarios. And that's true. That's a lot of the scenarios. But another common scenario I see and that people ask about sometimes is, what do you do with a family member, friend, coworker who maybe previously was taking COVID much more seriously? Maybe they're open to doing that again, but they've fallen out of doing mitigation, or they're not attending to how bad the situation is currently. And that's a little bit different of a scenario. And I have a trick that I like to use for that, and nothing's 100% effective, but I think it's good in this kind of scenario where you've got somebody who's a bit more well-intentioned or open to listening. And what I do is I give people information, or resources. It could be masks, it could be tests, it could be an air cleaner. And I will present this to them as something that is so obvious that they already know it, whether they actually know it or not. And I'm giving it to them so that they can share the information and be ambassadors to other people. And it's giving people a level of credibility and respect. You're acknowledging that these are things they know or should know, and that they can be empowering and helpful. And it's taking some of the pressure off of them, because you're not telling them to change anything. You're encouraging them to take a more powerful role where they can help other people and become greater experts themselves in these topics. And I found that to be a pretty helpful approach. And when I tell this to people, sometimes I will tell people what I just said, and then I will do that with them, and it still works. I say, hey, this is my approach where I tell people you are to go empower others, and then I give them the masks or I give them a graph or something, and it still works, right? So I don't think people feel like they're being used. It's just, oh yeah, that is a good approach, and thanks for respecting me and giving me this information or these helpful resources.
That's an interesting technique. I never thought of that. So that basically turns them into the experts and allows, as you said, empowers them, and hopefully they become ambassadors. Thanks for that technique. Um, so we have the situation where children are, I kind of feel like I'm asking the same question over and over again, which is basically, we have a society where a minority of us are taking mitigating steps like mask wearing, and in other key places, areas in our life, others aren't. And one of those places is the schools. And we have the kids returning to school within the next few days, returning with very few mitigations in the schools. And I just want to point out to people, because again, you've addressed kind of how to speak to people who are not in agreement with mitigations, but you put out a helpful tweet, maybe it was a few days ago, that included a letter to the schools that parents could present to the schools that made the case uh, to school administrators, that makes the case for why mitigations are important, and provided some scientific evidence for that. Is there anything more that you can add to that?
Uh,
I think
yeah, sure.
David,
I
I think David put
I
it
could
in,
talk about that
yeah,
all
I think
day.
David put it in the net.
So first
Yeah.
of all, I have 3 children. If I think about the factors that got me interested in COVID mitigation, one of them was that my son was just under 2, was in preschool, pulled him out of preschool, and we hoped that he would be able to go back at some point. Now I have 3 children, 5 and under, a 5.5-year-old and twin 1.5-year-olds, and we homeschool all 3 of them. So my situation is different than others. We haven't felt like the situation is improvable locally. It's all very bleak, and the places that were at one point trying have since, I would say, mostly given up. The weird situation here was that for a while, there were schools and preschools that required masking, and there were ones that didn't. The ones that didn't require masking tended to have good ventilation, though not always. Like some of the private schools had very good ventilation, but didn't require masking, and kind of were in that affluence, privilege sort of mindset. But the places that required masking, were public or lower income, lower cost preschools and that sort of stuff. But in my experience, had absolutely terrible air quality, and now many of them, well, all of them, I don't know of any that require masks. And if you walk into them, 1% or 3% of kids are wearing masks, and I don't know if I've ever seen a child in a New Orleans school wearing a mask correctly, in a way that fits well, since masks have become optional. So often it's below the nose and a cloth mask and that sort of stuff. So it's pretty bleak locally, and that's true, for many places, of course. So how people navigate that, I have immense empathy for. I wrote that letter to try to be helpful to people, and the way I took it was people would hopefully write their own kind of letter or email, and maybe include what I wrote as an attachment with references and figures and all that, or they could take my references and figures and disregard my letter and just write up their own thing, or that might just inspire them to be helpful. That it might be helpful. I don't know that it's always very effective, especially long term. Maybe it will have some short term benefit. I think the main way that those sorts of letters have an impact is unfortunately after a big surge where schools did nothing and lots of kids got sick and family members got sick and maybe hospitalized, or maybe somebody dies or becomes disabled. And then eventually there are lawsuits or people get fired, or that sort of thing. I can tell you that with my own advocacy efforts here locally, I was very outspoken leading into the BA1 wave and the initial, the biggest Omicron surge. And because it was absolutely apparent how bad that was likely to be with, 4 to 6 weeks notice, probably 5 weeks notice. And that was before I was doing any sort of formal forecasting stuff. That was just tracking the world events. And the situation obviously escalated very, very quickly. And there were three main people who stood against what I was trying to accomplish locally, and I can say they've all been fired. And I was not involved in their firing, but that's what eventually happened. And so there may be consequences for people who stand against the health and safety of children.
Let's hope, but for all of us and for you, we know that it's a very painful thing um, to watch the school system and learn the hard way, and for children to have to suffer and their families have to suffer as a consequence. But I know that as part of your tweet, you offered to, if people messaged you, that you were willing to send them a copy of this letter as a PDF, which they could then revise and and use themselves. So that's something I've really appreciated from you, is your accessibility and your willingness to really do real time advocacy. So thank you for that.
Thank you. I mean, it's just an absolutely terrible situation we're in, and so I try to help as much as I can. I hope some people are experiencing successes, and any improvement is a success. So if anyone can do anything to get better ventilation or filtration in their schools, that is a huge benefit. That's reducing likely the number of infections that individuals experience in a particular surge. That's reducing cumulative infections. And so that's a very big impact that people can have. It's just frustrating because the people who care about this the most, um, you know, even if their kids are fully on board and the kids and parents are doing everything they can, it's still a ridiculously risky situation at most schools, because even if you have kids wearing well-fitting, high-quality masks, they're going to be exposed likely at lunch and other times throughout the day. So um, I just have a lot of empathy for what people are dealing with.
Thank you. Mike, I'm very conscious of the time. I know that you're very busy and that you really had allotted only an hour to the space. How are you doing for time?
I could stay for about 20 more minutes. I've got to call some patients and I have a hard stop at the end of my day, but I could stay for about 20 minutes. And if there are questions, I haven't been looking to see if people are posting questions or if you're getting any behind the scenes, but I'd be happy to talk a little bit more.
Okay, great. Thank you. Um, yeah, so 20 minutes. We have a lot of people in the community with long COVID. And so, by your estimate, in the US alone, there are between 12 and 48 million people currently experiencing long COVID. Um, what do you view as the most promising leads in terms of treatment for long COVID? And aside from not becoming infected, is there a method that you recommend for, of course, we recognize that you cannot give medical advice and people need to consult with their doctors, but is there a method you could recommend for an infected person to decrease the chance of acquiring long COVID?
That's a great question. That's a bit too far outside of my expertise because I think I view the situation as pretty bleak generally, and so you would need somebody who has very specialized medical expertise to suggest, given what a patient's history is and current issues are, what would potentially be most helpful. I would think that the evidence suggests that people should be getting Paxlovid to the extent that they're eligible for that. But in terms of longer term, it's mostly about treating the specific symptoms and sequelae that people are dealing with. I don't see anything that's suggesting there's some sort of silver bullet, and so that's obviously very frustrating. I wish it was just a matter of telling people, you should go use this treatment. There's this really good treatment out there. And I was a bit naive on this, like a year or so ago when the long COVID clinics were popping up more. I thought they would be a lot more helpful and that there would be more specialized expertise than what there actually seems to be. And I think it's very frustrating for people because the wait times are often very long, and then the advice is very generic and unhelpful often, and patronizing, and at least some of the long COVID clinical work I'm familiar with, there's not even much of an emphasis on masking or much discussion of masking. I mean, it's good to encourage people to stay up to date on vaccines, but I think masking should warrant a lot more attention too, because of the importance of cumulative reinfections. And that's why one of the many reasons why I take COVID mitigation so seriously is to reduce my lifetime number of cumulative COVID infections. So sorry, I don't have a better answer for that.
Have you yourself been infected, Mike?
To the best of my knowledge, no, but there's like a discussion on Twitter and probably other places about Novid and all that sort of stuff. Myself, working at a university, one of our university's approaches was very testing focused, extremely testing focused, with tons of PCR testing very, very frequently. And I forget when that ended. It's been at least a year since they shut down their PCR testing program. But at one point, it was like people were getting PCR tested. Some people were getting it daily. Students, if you were in a dorm that had like a lot of infections, but most of the time it was like, weekly or every other week or something like that. And, my family uses rapid testing and buys rapid tests more than probably any human should. So we're very pro testing, test a lot. And that said, you never know for certain. So one of the things with rapid testing is that I see a lot on Twitter is there's like a lot of, I would say, unfounded hatred of rapid testing or minimizing the importance of rapid testing. And I view rapid testing as having two main sorts of purposes. One is diagnostic. I've got symptoms or I've had an exposure. Do I have COVID? And the other is reducing exposure to somebody who may have COVID and is unaware of it. So you're seeing a family member, you're both very pro COVID mitigation, and you're using a rapid test as an extra layer of protection to reduce your chances of getting infected. And so there's these two scenarios in terms of casehood of diagnosing, does somebody have COVID? One of the challenges with rapid testing is it may not catch if somebody has a very low infectiousness level of COVID. And so you may think you've never had COVID, but it could be you had COVID and your level of infectiousness was very low because maybe your exposure wasn't very long, maybe you were recently vaccinated, and any of these other good sorts of things that we would hope. But you could still have COVID and you may not know it, and I accept that as a reality. Um, and part of that is we know that cumulative reinfections are bad, and so I think it's important for people to grapple with that level of uncertainty that you could have had COVID and not realized it. And that might mean when you get what you believe is your first infection or your second infection or whatever you believe it is, you could actually be farther along that reinfection continuum that you realize, and you could be headed for some pretty serious health consequences because it may be more reinfections than you know. The flip side of that is that rapid testing is really, really good for detecting if somebody is highly infectious. And if somebody's highly infectious, you want to avoid them. Or if you're highly infectious, you want to avoid being in others' presence. So the best available rapid test I know of in the US is typically marketed as FlowFlex. They also market it as OnGo in the OnGo 1 packs. There are OnGo 2 packs that are made by a different manufacturer that supposedly have a slightly worse sensitivity and specificity, at least in the data that they've submitted. But these are really good tests. And if you read the statistics on their own testing processes, those are all focused on casehood, excuse me, and they do pretty well there. But if you're looking at them in terms of their sensitivity and specificity with regard to highly infectious people, they perform extremely well. And I'll post something updated about that soon. There was a great preprint on this topic that came out a while back and said something like the FlowFlex test for high level infectiousness had something like, I think it was 92% sensitivity. And going through their tables, I suspected that they actually transposed two of their digits, that instead of it being 92.8, I think it was supposed to be 98.2 or something. And I've seen that they've updated their preprint, and that was actually a typo. And these tests have even higher sensitivity than what they initially said. It's more like 98% sensitivity. And so if you can use a test like that and you can combine it with other things like high levels of air cleaning, well-fitting masks, outdoors, some combination of these, it's a very good risk reduction approach that I see people underemphasizing. And you want to think seriously about whether you would give up one layer of mitigation for another. But if it's something you can add on, that's just a tremendous way of reducing risk of infections. But to the best of my knowledge, I haven't been infected with COVID, and I acknowledge that there's uncertainty with that because I'm always up to date on my vaccines and could have had a low infectiousness case in the rapid test era that it was unable to pick up on.
Okay, yeah, I want to let people in the space who are located in Ontario, want to let you know that right now, FlowFlex tests are being distributed cost-free at, they used to be at grocery stores and pharmacies. And the Ontario government was taken to task for purchasing $2 billion worth of tests that had misrepresented their sensitivity level. But now those tests that were in the green boxes appear to have been replaced by FlowFlex tests, and those are available at, I know, Shoppers Drug Mart, Rexall pharmacies. So just wanted to let the people know who are based in Ontario that those tests are available to you. Okay, Mike, to close it out a bit, I know you don't have a crystal ball, but if you did have a crystal ball, how do you see this ending? What do you see as being the likely ending? Do you think the answer could lie in development of sterilizing vaccine, or or do you personally think that the answer is going to lie in more effective therapeutics? What do you feel is the most promising lead, and what stands in the way right now of finding the answers?
Yeah, the pandemic will end in about 2 months. No, obviously nobody knows that. And if anyone tells you that, they're trying to sell you something.
Yeah.
In late 2020, we started working on this theoretical paper and a grant application that ultimately led to our a funded grant doing some pandemic related work in the local food services industry. And if anyone wants to search my Twitter page, search for the word nightmare, and you'll find a nice graphic. And in December 2020, we really, I saw in the US, we were transitioning from the Trump era to the Biden era. And I saw the Biden leadership of who was going to be running the COVID response. And it was absolutely concerning. It was almost entirely physicians and often with very, very little expertise in public health and human behavior. And what you really need for a response to something of this magnitude is tremendous multidisciplinary and transdisciplinary expertise. And that was a huge reason why we shifted focus. My lab was doing cancer research, and we basically shifted half of our focus, roughly, to pandemic related issues at that time, because to me the transition team was quite disturbing in terms of their lack of expertise, which suggested that the pandemic would continue much longer than people had previously thought. But anyway, so if you search my Twitter page for nightmare, you'll find this graphic we came up with. And sort of our worst case scenario that we could envision was stuck in a nightmare, is what we called it, where there continued to be all of these viral variants, and there was very, very low utilization of new vaccines. And looking back at that, I think our worst case scenario would now be considered a very rosy scenario, because now we're doing so little on COVID that it's just extremely problematic. And if as a group we were to brainstorm 100 things we could do to make the pandemic situation much better, we would come up with a pretty reasonable list, and it would be all the things that we should be doing, and we're doing hardly any of them. So this is really a self-inflicted scenario by society that we're doing so little. And just one of the most obvious things I think of is it was shocking to me that within a month or so of the pandemic onset in the US, that we did not have low cost, highly effective rapid tests. And we still do not have that in the United States anyway. The rapid tests that I've described that are very good for detecting high levels of infectiousness, they're still about $650 each. And sometimes you can get them on sale for a little bit lower, but really these should be free, widely available, or so low cost that the cost is negligible, 10 cents a piece. We should have pooled rapid testing that you can easily buy. Right now with these rapid tests, if you get additional nasopharyngeal swabs, the most you can do with like a FlowFlex is like 2 or 3 people per test. We could easily be including more reagent with each of these tests, so people could, for a very low cost, test 5 people, 10 people at once, test 20, 30 people. So every day when kids come to school, they're getting a rapid test, and all of that would cut transmission immensely. And and that's just one thing that's extremely obvious that we could be doing that we're not. So will we get better vaccines? Probably, but I don't think anyone knows when that will be. If you look at how pharmaceuticals are developed, it's just a very risky process. You can't tell early on in a pharmaceutical development process what the winner is likely to be. It involves making a lot of losers, and then eventually one of the things you've invested in pays off. So it could be a very, very long time until there's a highly effective vaccine in terms of cutting transmission. And that's how I see things going, or hope that's where we'll go, is towards a more effective vaccine scenario. The situation of improving treatments is that could happen, but it's not a public health approach. That's a biomedical approach. And it's problematic because it's allowing people to get infected. And the consequences of infection could be in areas where we don't have treatments, even if there are certain elements of long COVID that we can treat. And so, and that assumes that people are getting diagnosed accurately and early and all that sort of stuff. So how it ends, I don't know. Nobody knows. Anyone who tells you is probably trying to sell you something. I will know that the pandemic has ended when I walk into a building and forget to put my mask on, or realize I've forgotten my mask and don't care about that. But I don't foresee that happening anytime soon. And I would encourage people to really take that long view of, if the situation continues to be this bleak for the next several years, what are the long-term investments you need to make now, to the extent that you're able to, that can improve your situation and your family's situation? And I encourage people to think about that sort of question every few months. Is there something you could do that would involve a radical change, switching from in-person work to remote work, homeschooling instead of having kids in-person learning, learning more about testing if testing hasn't been a core component of your multi-layered mitigation, doing fit testing for masks. If you have never done a fit test, you can search my Twitter page for DIY, should probably bring it up, and I've got very lengthy instructions on how you can do a do-it-yourself fit test for pretty low cost. And if you're not doing much on air cleaning at your home, or if there's room for improvement at your school or workplace, what can you do to invest in that? So that's how I would think about it long term.
Thanks, Mike. Yeah, David has put many of those tweets of yours that you're referring to up in the nest and in the chat if people want to refer to them later on. But here may be it's the last and maybe most important question of the day, which is how do we make sure that you remain on Twitter? Because scientists are leaving us in droves. I know you have the technique down for controlling trolls because you did a lengthy post about that, but how do we make sure you stay here? Because we need you.
Oh, well, thank you for such kind words. I'm not going anywhere. I'll be on Twitter. I can't imagine what would get me to leave. I was disheartened to hear that Dr. Moriarty is planning to leave Twitter. It doesn't make sense to me why so many people are leaving, unless they have, if it's a company and there's some advertising issue where their ads are getting put next to hate speech or something, that's one thing. But to go from Twitter with all of its problems to a smaller platform, to me, you may end up interacting with even fewer people. So it doesn't make a lot of sense to me personally. But but I don't use Instagram or TikTok, so there's bigger platforms people could use, and maybe that's what they're thinking. But I'm sticking around. It's funny to me, just from my business training, of there's this term called switching costs that people don't always think about, but it's like if you've ever had a cell phone where your service isn't very good or there's something you hate about it, but you've had the same service for like a decade, that's switching costs. Once you're locked into something, the costs of changing are quite immense. And so when people say they're going to go from Twitter to something else, I'm just thinking like, okay, see how that works out for you. It's developing your follower base and finding all these accounts and learning the quirks of how things work on that just seems like a lot to me. So I'll be here.
Okay. Well, I don't want to keep you much longer. I just want to thank you for your time, your commitment to keeping us informed and safe, and your quest to seek solutions. Thanks to everyone who came to listen to the space. For those who were unable to attend or who came partway through, or if you just want to re-listen, a copy of the recorded space will be pinned onto my profile. And maybe Mike, maybe you can pin it to your profile as well. Feel free to retweet and or to invite friends and family to listen. So that'll end the space for this afternoon. I'm sorry we didn't have time this time for questions. I'll leave the space open for a few moments for those who wish to look around the room and maybe follow other participants. Otherwise, thanks again for coming, and we'll see you next time. Thanks so much, Mike.
Thank you. I really appreciate everyone being here and look forward to engaging with you all more in the future.
Thanks.